So we're going to move on to our next speaker. That will be Dr. Jan Liefers from Leiden University Medical Center. He'll be presenting GS510, the utility of 70-gene mammoprint test for prediction of extended endocrine therapy benefit in patients with early-stage breast cancer in the IDEAL trial.
Thank you very much. I'd like to thank the organizers for giving us the opportunity to present our abstract. I'm actually presenting on behalf of Dr. Liefers, who also acknowledges being delighted to be selected. These are our disclosures. So the focus of this presentation is who benefits from extended endocrine therapy. Extended adjuvant endocrine therapy beyond 5 years is an option for all patients with a prior history of invasive estrogen receptor positive early breast cancer. 10-year endocrine treatment benefit is modest, and the effect may be dependent on treatment sequel and patient subgroup, and is of course accompanied by increased adverse effects, as I've seen in a number of clinical trials that have been presented in the past. Some patients may be more likely to derive benefit than others. Genomic classifiers that predict risk of late recurrence and benefit from extended endocrine therapy may assist with treatment decisions to recommend extended endocrine therapy. So the mammoprint test provides the opportunity to actually recognize a subgroup of patients that is low risk for recurrence, but low but not ultra low, and those patients, low not ultra low, have specifically a risk for late recurrence, and are those the ones who benefit from extended endocrine therapy. We tested the mammoprint test first in the NSABP B42 trial, and these data were presented at ESCO in 2021. And this is one summary slide of the data. In NSABP B42, after 5 years of endocrine treatment, patients were randomized versus an additional 5 years of letrozole versus placebo, resulting in a group that had 10 years endocrine extended therapy versus 5 years standard therapy. As you can see here, indicated in the red boxes, is for all endpoints, specifically the low, non-ultra low group, who has an absolute benefit of adding an additional 5 years, which is significant. We now take our opportunity to actually look at this in the IDEAL trial. Here's the trial diagram of the IDEAL trial. It's a prospective randomized open label phase 3 trial of postmenopausal patients that are hormone receptor positive early stage breast cancer and who had completed an initial 5 years of adjuvant endocrine therapy, and within 2 years they were randomized between an additional extension of 2.5 years letrozole or 5 years. And this randomization actually was for most patients done within 6 months after completion of the first 5 years. The overall IDEAL trial primary results published in 2018 showed no superiority of 5 years versus 2.5 years extended endocrine therapy in the 824 patients that were enrolled in the trial. There was no statistically significant improvement in either one of the endpoints evaluated. So here we now are looking whether the mammoprint stratification, and with specific interest in this mammoprint low, not ultra low group, can actually provide guidance who may benefit from extended endocrine therapy. So the objective of the study is to find out about the utility of the mammoprint test to identify patients who are likely to benefit from extended endocrine therapy, and in this study, 5 years versus 2.5 years extension. Of the eligible patients, of 869 specimens were available to do a molecular test, and of those we included about 500, and some patients were excluded who had follow-up events in the first 2.5 years of extension to get an equal comparison between the two groups. So we ended up with a translational cohort of 515 patients, and the median follow-up of this group after the randomization is 10.2 years. The endpoints evaluated are distant recurrence, a recurrence-free interval, and breast cancer-free interval. The statistical considerations were differences in primary and secondary endpoints between the 5 and 2.5 year extension were assessed by stratified log rank tests. The hazard ratios were calculated based on a stratified Cox proportional hazard model, and a likelihood ratio test evaluated treatment by mamaprint risk group interaction. Kaplan-Meier estimates are used for illustration purposes. So first, if we look at the cohort characteristics, in the middle you can see the patients that were included in the 515 translational mamaprint cohort. And on the right you can see the whole ideal cohort as had entered in the trial. So what you can see here, there is no difference in clinical characteristics of the translational cohort as compared to the whole ideal cohort. And data that I'm not showing, that there was also for this translational cohort no benefit or no difference in benefit between the 5 and 2.5 years extended endocrine treatment if the whole patient population was unstratified. So now if we look at stratification of this translational cohort by mamaprint, on the left you can see the mamaprint patients whose tumor were high risk, and on the right the ones who are low risk. And you can see that on the right the benefit of the extension of endocrine therapy is seen for the mamaprint low-risk patients for this particular endpoint, which is distant recurrence-free survival. If we look at the recurrence-free interval endpoint, we see the same thing, that particularly in the mamaprint low-risk population, there is a benefit of the extension of endocrine treatment, in this case 5 years versus 2.5, and not for the mamaprint high-risk group. If we look at that specific group that actually has a risk for late recurrence, so this is the mamaprint low risk excluding the ultra lows, they derive the most benefit from extended endocrine therapy, which is highly significant. So all of these results taken together in one treatment shows us that for this endpoint of low risk but not ultra low, there is an absolute benefit of 10% for each of these endpoints 10 years after the start of the extension randomization. So this is highly significant, and one can also look at the relative benefit, which for each of the endpoints was between 50 and over 60%. So in summary, for this particular trial evaluated, mamaprint high-risk patients do not seem to derive a statistical significant benefit from extension. And actually, if you think about it, it's actually quite logical, because mamaprint high-risk patients have a risk for early recurrence within 5 years. Therefore, this is the group that gets recommended to use chemotherapy to prevent their early recurrence. The mamaprint ultra-low group in this particular trial was very small, but is also not likely to benefit because they have an excellent prognosis by themselves, and the NSABP B42 trial also showed that the ultra-low group did not benefit from the extension of endocrine therapy in that trial. So the low, not ultra-low group is really the group that has a risk for late recurrences, and they are the ones that derive benefit from extended endocrine therapy, and the risk reduction is quite substantial. In the ideal trial population, this group represents about 43% of the population. So if we look at the ideal trial and the NSABP trial together, so the difference is that in the ideal trial, there was a comparison between 5 years extension and 2.5 years extension. And in the NSABP B42 trial, it was 5-year extension versus placebo. And what you can see here, that in each of the trials, that it's particular in green, the mamaprint low, not ultra-low group, that has the benefit of the extension of endocrine treatment. So this has important implications to propose. Mamaprint is predicted of extended endocrine treatment benefit. High-risk patients can maybe avoid endocrine extension treatment, and the low risk are the ones who do benefit. I'd like to acknowledge for this study the 824 patients who participated in the IDEAL trial, the investigators and coordinators in 73 hospitals, and you can see here the trial registration in the Dutch as well as in the European trial registries. Thank you very much.
Thank you for your presentation. Question on number 3, please.
Patrick Neven from Leuven in Belgium. Laura, this is a very nice presentation. MammaPrint low-risk patients are from clinically high-risk and clinically low-risk patients. Do you need MammaPrint, or can you also go back to the clinical risk?
I think so. I didn't show you any data by stratifying this particular IDEAL population by clinical risk factors. But actually the investigators of the IDEAL trial did that themselves in previous publications by Block et al. And so they couldn't find by clinical characteristics like lymph nodes or grade any subgroup that would benefit from the 5-year versus 2.5 years of extended endocrine therapy. So this is the first stratifier that is able to identify such a group.
And did you look into the CTS5 score?
We did not look yet. We actually only very recently started this project, so we are actually looking also in other stratifiers that could do this and for comparison. But I think the strong result is that this IDEAL trial result confirms what was presented a year before in the NSABP B42 trial. So these are 2 large randomized trials that show the same result.
We have another question on number 5.
Yeah, just a nomenclature question. Hi, this is Kathy Graham from Atlanta. You know, it seems like we talk about low risk and high risk of recurrence, but what we're seeing is that it's early risk versus late risk of recurrence. And I'm just gonna, kind of challenge you and the audience to maybe think about renaming our risk of recurrence as early risk versus late risk. It's really intriguing to me that we can get this information from a single test, and I appreciate your presentation, but perhaps we ought to think about renaming our risk stratification groups as early risk and late risk rather than low risk and high risk.
I think that's a very excellent and intriguing suggestion. I think you actually have a very good point. Of course, both the MammaPrint as well as the Oncotype tests were originally tested to predict which patients needed adjuvant chemotherapy. And we know that the risk for or that chemotherapy is particularly beneficial for patients who have a high risk, and that high risk is actually all early. So when we started this whole sort of thinking about risk assessment, we didn't sufficiently appreciate early versus late recurrence yet. So I think now that we are actually seeing that a test like MammaPrint can also help to identify late recurrence risk, I think you have a good point. And I think on one of my earlier slides, I also indicated that there is a high risk for early recurrence, which is the benefit of chemotherapy group. And now we have this late risk, which is still relatively low, but a considerable risk that needs treatment.
We have time for a couple more questions. So number 4, please.
Vogel, New York. Hi.
Hi.
So the IDEAL study is very heterogeneous in the treatments that are given before the 5-year point. You have the tamoxifen-only patients who have seen no aromatase inhibitors, and from MA17 you'd expect more aromatase inhibitors to do a lot of good. You have patients who switched after 2 or 3 years, and you have patients who've already had 5 years of aromatase inhibitors. Does the benefit in the low but not ultra-low patients extend across all 3 of these groups, or is it particularly in one and not another?
I can currently not answer your question because we haven't done that analysis yet, and I think it's a good suggestion to do that. But the investigators of the IDEAL trial did investigate whether any of the extensions, 5 years versus 2.5 years, was more beneficial for one of these groups that had initially had only tamoxifen or a combination or only an AI.
One last question on number 3, please.
So Xintan, Mississippi. Rather than showing your MammaPrint predict the late relapse with a low risk, can we interpret the data as saying those group of patients did not get chemotherapy up front? As a result, they have a late relapse?
I think that's a very good question. I don't think we can actually conclude that from this particular trial, but there are other trials, and one that I'm very much involved is the MINDEC trial. And so from the MINDEC trial, we do know that the MammaPrint high-risk patients have in this prospective trial, the early recurrence risk. And we do see there also that the late recurrences occur in the low but not ultra-low group. We actually, that was an addition also to the previous question, the MINDEC trial, we have not yet presented the results of an endocrine randomization, which was part of that big trial. So we will focus the analysis of the endocrine randomization in the MINDEC trial also to answer this specific question. But for now, we know that the high-risk patients are all having early recurrences. It's maybe not, yeah.
Thank you.
Thank you very much for your presentation.